Good afternoon, everyone. Welcome to Mölnlycke's sponsored learning event. My name is Marika Slemko, and I am Mölnlycke's Surgical Solutions Manager. Our topic today is Rethinking Wound Care, Setting a New Standard in Wound Care, the Flex 360-Degree Revolution. I am honored and pleased to introduce our presenter, Dr. Kevin Wu. Dr. Kevin Wu is known as a leading Canadian researcher in the areas of wound care and chronic disease self-management, and has served on expert panels and advisory boards to develop the best practice recommendations. He received the Journal of Wound Care's the Best Diabetic Foot Ulcer Intervention Award in 2018. In 2020, he received the prestigious Order of Merit Award. Dr. Wu has authored over 150 peer-reviewed journal articles and 19 book chapters. He maintains an active clinical practice in acute and chronic care hospitals. Kevin is chair of the Joint Research Ethics Board for West Park Health Centre and Toronto Grace Health Centre in Toronto. He is the web editor for the Advances in Skin and Wound Care website. Also, he is president of the Canadian Pressure Injury Advisory Panel. Quite an impressive bio, I must say. I had to read that one. So welcome once again, and I hope you enjoy Kevin's presentation. And on to you now, Kevin.
Great, excellent. Thank you so much, Marika, for a very kind introduction. And welcome, everyone. It is such an honor to be sitting here to share with you my experience of using this dressing, flax and Mepalax flax dressing material. And I want to thank you for sponsor Mölnlycke Healthcare for this session. And I just want to provide some disclosure. I do work with a variety of different companies and organizations. And for the objective for today, what we will be talking about is to re-examine and appraise the burden and mechanisms of pressure injury, which I think a lot of you have some basic understanding about pressure injury already. So hopefully this is a nice sort of refresher for you to really appreciate the complexity of pressure injury development. I also want to appraise the benefits of using a prophylactic type dressing, flax foam dressing, and looking at the ability to conform to the contour of the body, the absorbency, and ease of use through a number of case studies. And I think the important part is to talk about how soft silicone dressing can be used for the treatment and prevention of pressure injuries and skin tears. Well, the $6 million question is, how common are pressure injuries? And this is a nice systematic review that was done quite recently, published in 2018. They looked at about 35 different published studies on different prevalence and incidence across different sectors in the healthcare environment. Looking at all the point prevalence and period prevalence studies, point prevalence of the studies, they evaluate the number of pressure injuries usually within a day versus period prevalence of those studies that may be done within weeks or sometimes even months. So on average, based on those 35 studies, they identify about 15% of individuals suffer from some evidence of pressure injuries. And the overall mean incidence of pressure injuries was about 6.3. So the difference between prevalence and incidence is incidence of the new cases once they entered into the healthcare environment. About 6.3% of those individuals would develop pressure injury under the care of healthcare providers, unfortunately. And there's another more recent study published in 2020. They basically also report the incidence rate of pressure injuries, about 12%, even higher compared to the previous study. The fortunate thing is most of those reported incidences were pertaining to stage 1 and 2 pressure injuries. And I have cut and paste some of the tables from that paper, really illustrating that most of the reported pressure injuries were the stage 1, 2 superficial type pressure injuries versus the 3 and 4, the deep pressure injury problem. And when you look at the variety of different healthcare settings within hospital environment, you can see that they're everywhere. In the ICU, there are a lot of studies done, 13%. In the emergency, about 6%. And in general medicine unit, general surgery, about 10%. So this is really alarming to see the high number of incidents and prevalence of pressure injuries, especially with the hospitalized patients. In Ontario, we did a study and published a few years ago. We looked at the data from CAI and the minimum data set from 2010 to 2013, including about 250,000 individuals. And we separate them into different sectors: acute care, health, home care, long-term care, and chronic care environment. As you can see, the highest number of pressure injuries are found in the complex continuing care environment. Those are individuals with ventilators, with feeding tubes. And one of my pet peeve is, and one of the biggest clinical challenge, if you may, is when patients are on tube feeding, the head of the bed is always elevated. And the key question is, how can we prevent pressure injury in the ischial tuberosity? What I'm sort of sad about looking at this data is the fact that from 2010 to 2013, practically the incidence and the prevalence rate has not changed significantly. So I think there's still a lot of work for us as Canadians to continue looking at different programs, protocols, education platforms to enhance practice and build competency at the bedside. And I think just to prelude, one of the organizations that I'm participating in is the Canadian Pressure Injury Advisory Panel. And we've been working closely and hopefully to work closer with Wounds Canada to really looking at how we can advance the platform for pressure injury care in Canada. As you can imagine, the care is quite fragmented. Our approach to pressure injury is very diverse and not always consistent. And we need to join forces and create a louder voice to canvas for government support. So this is just a graphic presentation in terms of our prevalence in Ontario. So for people not familiar with the CPF, the Canadian Pressure Injury Advisory Panel, we're an interprofessional collaborative group, and our mandate is to advance policy, to look at how we can advocate for patients, healthcare providers, and looking at policy development and also from a research perspective as well. So coming back to pressure injuries, just review some of the basic pathophysiology. The most common factor predisposing people to pressure injury development is due to pressure problem, and that's why we call it pressure injury. And as a result of pressure, and magic number is about 32 mmHg of pressure that is enough to close the capillaries, compromising blood flow, and as a result of that, it can trigger a whole cascade event leading up to ischemia, occlusion of the lymphatic blood vessels, increasing capillary permeability, and causing interstitial fluid to collect locally and edema. And I think what I'll do is to draw an arrow from edema to decrease capillary blood flow. And sometimes people refer this to as edema-induced related injury or circulation problem, because with edema, it puts pressure around the blood vessels that can compromise capillary flow locally. And I'm sure we're all aware of the differences between shear and pressure. Pressure is the perpendicular force against the tissue versus shear usually is the oblique force separating the top layer of tissue from the deeper compartment. And what we have known about pressure injury is the importance of soft tissue deformation as well. And from some of the work by Dr. Gavin that I think he presented in this conference a couple of days ago and had a very insightful discussion about these dressing selection, tissue deformation can actually induce more rapid cell death compared to the damage from pressure and shear. We can estimate the tissue damage due to pressure and shear can occur within hours, but not to forget soft tissue deformation. those damage can occur within minutes to hours. And the mechanism is quite complex, and I'm not going to pretend I know everything about the physiology behind deformation or tissue deformation. What's involved is, because of shear pressure and other mechanical forces, the mechanical signal is transmitted into the cytoskeleton. And the cytoskeleton can transmit all those different mechanical forces to the signaling cells and influencing the genetic expression eventually. So it can have a downstream effect in terms of protein expression, tissue apoptosis, cell death and survival, the rate that the cell is proliferating and differentiating. So it has a huge impact. And that's why when there's significant amount of deformation affecting the shape, the structure of the cytoskeleton, the cell can die quickly. Okay, here we go. Moving forward. And this is a very informative slide from Lustig and his group, really looking at the different type of damage on the tissue on the cellular level that eventually result in pressure injury. Here you have the ischemic damage, inflammatory edema-related cell damage, and then the tissue deformation. And what's important to notice on this slide is the fact that the delayed effect of the ischemic cell damage compared to the direct deformation damage, which occurs much earlier on. In combination with the cumulative effect, you can see that this really sharp rising curve exponentially increasing the rate of damage at the tissue level. The other mechanism that results in pressure injury is related to lymphatic dysfunction. And this is a nice study done by Gray and his group, looking at the machine here, applying pressure directly to the forearm, occluding the lymphatic flow. And as a result of that, increasing lymphatic pressure locally. And again, it can stimulate, trigger these inflammatory cascade events. We know that inflammation can be very good, but for prolonged excessive inflammation, it can damage the local tissue, causing further damage. So I think we can appreciate the mechanical forces, whether it's pressure, shear, tissue deformation, or the lymphatic dysfunction that result in pressure injury. But given the same pressure and shear, not every individual is going to develop same degree of tissue damage. So I think we appreciate also the tissue tolerance and intrinsic factors that make people more vulnerable to tissue damage. Well, who are those individuals? For example, we pay attention to individuals' nutritional status. And this is a study published a few years ago, looking at the relationship between BMI, body mass index, and pressure injury development. As you can see, the relationship is curvilinear. Basically, what it means is that individuals with very low BMI and very high BMI are at high risk for developing pressure injury versus people with the normal range of BMI. More importantly, in a study validating the fact that yes, people with low BMI, they're at risk, people with high BMI, they're also at risk. But don't forget that even people with high BMI, it can be separated into the malnourished group and the well-nourished group. Just because people are obese doesn't mean that they're eating properly and have the proper nutritional status. And this is the more sort of hot off the press update on the relationship between nutrition and pressure injury, really validating some of the findings, the earlier findings from other studies already. But they, in this sub-analysis, what they have confirmed or validate here is the stronger relationship between pressure injury and the low BMI group. And it's really interesting to see that that people emaciated, people who have a very low level of albumin, people who are losing a lot of weight, they're really at high risk for developing pressure injury problem. And of course, in this conference, there will be a lot of discussion about nutrition. There are more knowledgeable people from the dietary science to talk about the importance and management of nutrition. But I think I love this slide, just really highlighting the key points here with pressure injury, the draining of fluid, we're losing a lot of protein. Because of the injury level, there's a catabolic response resulting in as a result of chronic inflammation. And the inflammation can be triggered by the presence of the pressure injury or other comorbidities that person is experiencing. So I think you can see that this is kind of a vicious cycle. The other factor that can predispose people to the development of pressure injury is the concept, what we call microclimate. There are two major factors that constitute this important concept. One is the relative humidity, the amount of moisture on the skin level, and the second factor is the temperature. And in fact, there was a study done to validate the fact that 1 degree increase in the skin temperature can increase the metabolic demand by about 16%. So you can imagine that individuals who are catabolic already, they're using a lot of energy, they need more energy, they're emaciated, they don't have a lot of blood flow to the local environment. Now there's increase in metabolic demand, and that's why the tissue can become more vulnerable to pressure damage. And the other important factor is the moisture level, the humidity on the skin. The reason is with the increased moisture, it can increase the friction and shear coefficient, making the skin more likely to suffer from significant amount of force in the triangulation of blood vessels as a result of shear problem. So what we see is people who have microclimate problem due to double incontinence about 5 times more likely to develop pressure injury problems. And some of the recent studies that we've been doing is to use leverage on artificial intelligence to collect real-time continuous data on the pressure, temperature, moisture level to evaluate patients who may be at risk for pressure injury problems. And this is a poster that I think got accepted for a number of conferences, comparing the device ability to detect moisture level versus the nursing assessment on a more frequent basis. And there's a very, very good degree of agreement between the two types of assessments. A growing concern around pressure injury is the medical device-related pressure injury problem. In fact, in one of the smaller studies, they look at 93 patients, about 62.4 patients, individuals in the study develop medical device-related pressure injury. That's a very high number. And those injuries can be related to nasogastric tube, urinary catheter. As you can see, even sometimes the clip that we use to secure catheter, trach ties. I think during the pandemic situation, I'm seeing more and more people staying in bed. A lot of times they may not have the fan turned on because with the respiratory and with the control of airflow, we don't allow patients to turn on the fan. So a lot of individuals suffer from sweating problem. And with the sweat, with the pressure, with the increased heat, a lot of individuals develop this type of pressure injury as a result of medical device pressure. So the key around the management and prevention of pressure injuries can be summarized by skin. I like this acronym not only because it's easy to remember, but also emphasizing the importance of a bundle approach. There's no one strategy that is going to be most effective to prevent or care for pressure injury problems. But we do need to think about a very comprehensive approach. Think about S for surface, S for skin inspection, K for keep moving, I for incontinence care and moisture control, and N for nutrition and hydration. So the focus of today's talk is just looking at from a topical perspective, can we do something? Can we apply a prophylactic dressing to prevent pressure injury? And understanding there are other components and other strategies that you need to put in place to create this comprehensive care plan. So this is a study published this year in the Journal of Wound Ostomy Continence Nursing. They look at the studies that has published evaluating prophylactic foam dressings for prevention of hospital-acquired pressure injuries. They identified 14 studies that fit the inclusion criteria. And what they have found was, yes, by using prophylactic dressing, foam dressing, we're able to reduce sacral hospital-acquired pressure injuries, particularly in critical care patients. What about surgical patients? And this is a study published in 2018 comparing soft silicone foam dressing versus a polyurethane film material that is placed under those vulnerable areas when patients are undergoing spinal surgery. And this is a randomized design study. And what you can see here is they apply dressings on the chest and around the hip area on the iliac crest, where those areas are most vulnerable as people in a prone position. So you can see that there's a significant difference between soft silicone and polyurethane film, with a lower incidence of pressure injury in the soft silicone foam dressing group. So the Mölnlycke dressing has been around for many years. I remember that, well, I'm not going to tell you how long I've been in wound care already, but for the years I've been practicing, I have known this dressing for very well and have applied on many patients as well. So the evidence is quite convincing. There are many case control studies, randomized control design studies, and as you have seen earlier, many systematic reviews and meta-analyses as well. Overall, I think there is a significant reduction in pressure injuries with the use of Mölnlycke dressing from 2 individual studies, including acute care patients and chronic patients. So based on the convincing and the strength of those evidence, the most recent pressure injury guideline from the NPIAP and the EPUAP, they made 3 very important recommendations pertaining to the prophylactic use of foam dressings for prevention of pressure injuries. First one, 3.5, uses soft silicone multi-layer foam dressing to protect skin for individuals at risk for pressure injuries. B1 evidence. 6.4, use a prophylactic dressing as adjunct to heel offloading and other strategies to prevent heel pressure injuries. And we understand that heel pressure injury is a very common problem. In fact, it's a growing concern because there's a lot of pressure and a lot of problems in those areas. 8.5, use a prophylactic dressing beneath a medical device to reduce the risk of medical device-related pressure injury problems. And as I've shown you earlier, some of the data, the high incidence and prevalence of device-related pressure injury, we need to be more aggressive and have some better programs and standards to prevent this type of problem. So how does it work? Why do we think that foam dressing can prophylactically prevent pressure injuries? I think there's a number of mechanisms. With the multi-layer foam dressing, a lot of times those layers can move against each other to displace pressure and shear. The silicone material, particularly soft silicone material, they have the elasticity that can help disperse the mechanical forces. And not to forget about the type of material they incorporate in the foam material. And I'll come back to talk about some of those key properties. The stiffness and the bendability or the flexibility of those material has a lot to do with how it can disperse and displace some of those local pressure and shear problems. Just to remember, there are many different foam dressings out there, and each dressing is quite different compared to the other based on the composition, the thickness of the material, the number of layers incorporated in the foam dressing. Not all foam dressings have multiple layers of the 5 layers. And that would explain some of the differences in absorbency, the different shape, and some created or designed to stay on better in the sacral area versus some other designed to facilitate the ease of use around heels. The adhesive properties, some dressings use silicone interface, some other may use more aggressive adhesive material. So the type of adhesive has a lot to do with the amount of force required to remove, and also there are some other important considerations, including antimicrobial agents that get incorporated in the dressing material. So another important concept is even with the foam dressing, they're quite different because it depends on the foam, the pore sizes and the pore structure inside the foam material and how they interconnected with each other. It could explain the way that they can transport the fluid, handle the fluid exudated produced from the wound environment, and the more important aspect is to retain and lock the fluid inside the dressing itself. So this is a slide actually borrowed from Dr. Gavin's talk, and he talked about from a engineer's perspective how he approach different types of dressings, looking at the structure and looking at the mechanical physical property of the material. That can explain some of the clinical functionality that we see upon assessment. So for people not familiar with the flax material, it is a newer generation, if you may, of the Mölnlycke family. And it comes in different shape and sizes, and this is a rectangular shape. It has multiple layers, including a wound contact layer, a foam pad, a drainage dispersal layer, drainage retention layer, and the waterproof backing film, the waterproof film backing that allows some vaporization to occur. The important part about this interesting dressing is the presence of those wide cut on the back, allowing the material to be stretched more easily. The other important part, similar to many Mölnlycke material, is the SafeTech soft silicone material interface that allow a traumatic removal of the dressing, doesn't cause any skin stripping and trauma to the fragile skin. And this is a slide just to show you how engineers the work in terms of comparing different types of dressings and looking at the physical property, the mechanical property of individual dressings and the performance. So subjecting the dressing to this shear forces from a weight on top of it and dragging along the dressing surface, and see how much the material is being stretched over time. And you can see that Mölnlycke is performing much better compared to control dressing in a way that it doesn't get stretched too much, so it's able to maintain this integrity over time. And they also have done some lab study to examine the X-ray handling capacity. As you can see, the Mölnlycke is slightly better compared to other competitive dressings out there. And due to this superior fluid handling and retention property, one of the interesting proposed mechanism along with the fluid handling is the bacteria trapping action. So as you can imagine, there's a lot of bacteria in wound fluid, and as the dressing wick away the fluid, soak up all the excess exudate, and along with it, inside the exudate, you also have those bacterial pathogens, agents that can actually be locked in the dressing itself. And that's the key concept behind bacteria trapping in action. So even with the pressure, the fluid would not be able to donate back into the wound bed, so there's no bacteria that can re-enter back into the wound environment, in other words. So if you want to see a comparison study, this is done in the lab as well, comparing the Mölnlycke flax material with another foam dressing after the bacteria was being added and putting a foam dressing on top, you can see the significant reduction in the amount of bacteria by using the Deflex material. So yes, I think we know that from a lot of the controlled environment, in the experimental environment, the material is superior compared to a lot of the similar type material out there. What about clinical performance? We want something that can handle the exudate, that can prevent infection, and most importantly, able to control the leak and without causing any maceration problem. So the conformability is an issue. Often when we see patients, when there's many challenges, and we often complain about dressings, they won't fit the area, and it doesn't retain the fluid. And the more sort of relevant question is does it really conform to the contour of the body, especially around the coccyx sacral area? You got this really interesting contour going on around the elbow, around the knee, around the heel. So dressings end up not staying on the skin. We end up spending more money replacing dressing on a regular basis. And in many situations that you have a gap, you have this problem with proper adhesion. So fecal material can enter from the neighborhood, from the environment into the wound area. So I think that that's a major concern when I talk to infection control or infectious disease practitioners. They often ask me, Kevin, is there a new dressing that we can just cork up the area so we don't get any fecal contamination? Well, I hope that someone one of these days can develop something like that, and that will save us a lot of angst in terms of preventing an infection issue. Anyway, coming back to the Deflex technology, as the name implies, the material is created and designed such that it is more flexible and comfortable to wear. And the reason is because of those wide cuts on the dressing material, allowing the material to be stretched more easily. And the outcome perhaps is to allow people to wear the dressing for longer duration of time, able to conform to the body for in a better way, more comfortable to wear, and because of the ability to conform the contour, so it can seal off water, it can seal off other contaminants as well.
Lots of guys with guns.
So as you can see that this is an interesting case. I was using a fluorescence imaging device to evaluate bacterial damage in this wound. So you can see that this is a pressure injury on the coccyx area. I removed the dressing, and lo and behold, I didn't see a lot of area being illuminated by the fluorescence light, indicating there's really no bacteria underneath the dressing material. So the flex dressing was quite effective in creating a sealed environment. So the bacteria just actually build up in the region, in the border, outside of the dressing itself. So I think it's an important message when you think about the protection of the wound from bacteria, from other contamination. And there are a number of ways to look at dressing performance, and this is a study done by Evan Call and his group, and you can see that there's some other people from Australia and Israel as well. And basically, they look at a few parameters for this, what they call a macroscopic evaluation, asking nurses to evaluate what what the dressing looked like after a few days of wear time. So do they see there's any problem with wrinkling and bunging up, any fluid leakage, the layer separating, rolling, and any issue with the conformability, indicating the dressing no longer performing or meeting its expectation. So what you can see, they compare a few different dressings with Optifoam, Aleven, Aquacel foam, and Mölnlycke. And this, well, the important thing is they were very fair. And there's no one dressing that is superior in terms of in all the parameters. But because we have focusing on the Mölnlycke dressing material here, you can see that there is very little layer separation, and the conformability is quite good compared to other types of dressing material. So because of the ability to conform and the elasticity of the material they use for this type of dressing, and we understand that it doesn't get degraded quickly over time, and the flexibility allow the dressing to produce a very good, what we call axial stiffness, allowing the mechanical forces to be dispersed across the dressing material. Because if it's too soft, the mechanical forces cannot be dispersed evenly or dispersed from the local environment to the outside, to the border of the dressing. So I think the stiffness material, the type of material they use in dressing is very important to consider. And in the lab, what they have shown here is the comparison of different types of foam dressing following up with the macroscopic evaluation. And they were able to validate that under compression, with the Mölnlycke border material, they actually outperform other type of dressings in terms of the strength and the ability to resist the stress induced by stretching and other type of mechanical manipulations. So yes, we appreciate that the material has to be stiff in order to distribute and in order to disperse the mechanical forces like pressure and shear. However, it is a fine balance. You don't want to have material that is so stiff, like in this picture. Under compression, you can see that the stiff material actually creating a deep indentation in the peri-wound skin area. In fact, I got in a picture showing the individual after a few days of wearing this type of dressing under compression, resulting in some superficial skin damage because the edge effect of the dressing material causing pressure problem and cutting into the skin. So yes, I think it's important to consider the right amount of stiffness, right amount of bendability, the flexibility in the dressing material, but you don't want it to be too stiff either, especially around the border area. So in this lab study, they compare and evaluated this dressing material, and the pressure at skin level is reduced by 70% because of the ability to distribute pressure. And on the edges area, there's a reduction in stress by about 20% as well compared to some of the control dressings. So let me show you a few cases here before I finish my presentation. So you can see this is a pressure injury on an individual, and she's still actually in the hospital that I provide consultation from time to time. She is not very mobile, and she liked to be in a chair. She was very, very sociable, liked going around, seeing friends, going to the shop. So she ended up in a chair about 8 to 12 hours at a time on a day-to-day basis. And you can imagine she's incontinent, there's urine, there's microclimate that can create an ideal environment for pressure injury to occur. And yes, you can see that it occurred on the right ischial tuberosity. And we've been using different types of material. And at the end of the day, we still run into a problem with the dressing being drenched with urine, with material that is not supposed to be there. So we end up with a cheap and cheerful version of the dressing because we didn't think that it was helping anyway. So we are using a gauze material with iodine and then a mesor and then some film dressing to secure it. So then we come across the Mölnlycke flax. So I was told that, well, Kevin, you got this dressing, might as well do a little bit of evaluation, try on a few patients. And I thought, well, okay, I have nothing to lose, and this is a very challenging situation. And I try many foam dressings, they don't really conform to the area well, they don't seal up the area to prevent the urine contamination. So I did try the Mölnlycke flax on this individual. As you can see, around the gluteal fold area, the the area below the buttock region. It conformed to that fold quite nicely, and it doesn't bunch up, and the adhesive, the soft silicone material able to provide very nice edge around the area, creating a very nice sealed environment. So after a week, we came back to evaluate the local environment. You don't really see a lot of maceration. In fact, it looks a little better, isn't it? And then we continue with the dressing material, and then after 3 weeks, we're able to completely close this wound. And of course, we continue to educate the patient that she needs to offload the area. She needs to go back in bed from time to time to have the brief changed. She complied to a certain extent, or adhered to a certain extent, but not on a very consistent basis. So we can attribute to some improvement to definitely the dressing material that we have chosen. I like this picture for this patient. One is, again, showing you the conformability of the material to a very challenging location. And secondly, is this wound is actually quite productive, exuding a high volume of exudate. As you can see that there's practically there's no leakage around the dressing, and able to handle and lock the fluid in the dressing itself without causing any maceration and other sort of dermatitis problem that we often see when individuals produce a lot of wound fluid. Now, this is another interesting case, a patient with spina bifida. She basically immobile because of a spinal problem, and result in the situation that she developed dependent edema because she's again on the wheelchair most of the time. And we apply compression therapy, and there's no strength, there's no dorsiflexion, so there's a constant problem with the foot maintaining in the same position. So with the use of compression therapy and the foot being placed on the pedal, so result in a creased area that often the material, the compression material, can bunch up, creating a tourniquet effect and the pressure point. So yes, we can see that in the middle picture here. Now you have a pressure injury problem. We were using another foam dressing material with the intention that we want to offload, to reduce pressure. We want to protect the area from the pressure applied from the compression bandages. But it gets very mucky. It gets actually, in fact, it's not as healthy looking. A little more bleeding problem has occurred. So we again switch the patient to the Mölnlycke material under compression therapy. After 2 weeks, you can see the quality of the wound bed has improved, less drainage, there's no bleeding, no bloody, no old blood collected on the wound bed. And after 2 more weeks, this wound has completely healed. So again, the important message is the conformability, the ability to offload, and the ability to perform very well under compression therapy. And you saw the slide before with the very stiff material. It can create a lot of pressure in the peri-wound skin, especially around the wound edges. So again, we switched the individual to the Mölnlycke material, and we can see that with the proper compression therapy, this area has healed completely within weeks. More recently, we completed a randomized controlled design study evaluating silicone dressings for the treatment of skin tears. Dr. Kimberly LeBlanc, I think a lot of you are aware and know her work for skin tears. And we randomized individuals to 2 different groups. The treatment group depends on the type of skin tears. For the type 1 and type 2, with the flap still kind of available, we use the Mepitel 1 versus the type 2 and type 3. Depends on the amount of drainage. We apply the Mölnlycke or the Deflex material. In the control group, we use the all dress material, which is a non-adherent, non-silicone-based dressing. And we included 126 participants in the study, which I think is a decent sample size. Individuals aged between 45 to 102, different locations for the skin tears, and the distribution between the control and treatment group, they're very, very similar in the different locations and different types of skin tears as well. There's no really glaring differences across different groups. As you can see in some of my patients randomized to my hospital, and with skin tears using the Metplex material, we're able to, in fact, heal most of the skin tears within 7 days. And this is another superficial skin damage problem. We use the Metplex Flex material, and within a week time, this area is completely epithelialized and closed. So basically, the outcome from this randomized control design studies, we're able to see after week 1, about 50% of individuals actually achieve complete closure versus only about 10% individuals have completely healed wounds. By week 2, about 90% of people were healed. By week 3, almost every individual receiving silicone dressing treatment achieved complete closure. Versus, even by week 3, only about 1/3 of the individuals in the control group able to achieve complete closure then. So I think the most important message around the selection of dressing material, other than the performance, the mechanical properties, and also the healing outcome, we also have to think about patient-centered concerns as well.
Okay.
You can't do it. Don't do it.
Okay, we're done.
Please.
Okay.
Please don't do it if you
Yes,
can't
Mommy.
do it. I said, don't
Okay.
do it.
We're done.
Well,
Thank
as
you
can
so much,
see,
Kevin.
this is a very adhesive material, and the nurse was doing her best to slowly, gradually removing the dressing material. It was very sticky, very difficult to remove. It took us a long time to sort of a little bit at a time to remove the dressing material. I think literally it took us about 10 to 15 minutes to remove the dressing. And what you have observed here is the level of frustration, the agitation this patient is experiencing and displaying to us. It's just so difficult to see people feeling so powerless, so agitated, because the pain that we can prevent and avoid and mitigate. So versus now we actually switch her to a different type of dressing, and you can see the responses in during the dressing change procedure.
This is hurting.
I know, I'm so
Please.
sorry.
You're sick. Oh, I need a hand.
She's a good healing.
Oh. I just need a hand.
Just
Almost done,
close to the
sweetie.
skin, so-
Yeah. Yeah.
Okay.
Oh, it looks pretty good.
Yeah, it's pretty good for the patient, because we can avoid a lot of suffering. We can mitigate the pain by selecting the appropriate dressing. So I think emphasizing the importance of a silicone-based interface that can be more atraumatic and be more comfortable for our patients. So I think at the end, I want to reintroduce the acronym, the different parameters and factors that you might want to consider when you're selecting a dressing material: the dimension of the wound, the depth of the wound, the resources and costs associated with the dressing treatment, the X-ray level, how thick the wound fluid, the amount of wound fluid, the contour of the location of the wound. As for surrounding skin, is it fragile? Is it inflamed? Is it painful? I for infection, and for necrotic tissue, we need to put something and apply a dressing that can promote autolytic debridement. G for goals, thinking about what's healable and non-healable wounds. And most importantly, think about as for suffering, how we can, as individuals, as healthcare providers, as wound healers, we can reduce pain and reduce related symptoms. So I think hopefully you enjoy this presentation, and a lot of the material, probably a refresher for you. And I welcome any comments and questions at the end.
Thank you, Dr. Wu, for a very engaging and informative presentation. Now we'll take a look at the questions that we have received from the attendees. If you're ready to hear some of these. First one, I'm going to present to you very apropos in our environment of living with COVID in hospitals in the community and long-term care for the last 18 or more months. The question is, have pressure injury rates increased in the past 2 years due to COVID? If so, have certain sectors seen higher increases versus others? For example, acute versus long-term care.
Thank you, Marika. That's an excellent question. And of course, I think a lot of data is still emerging, and this will be a very interesting research question for us to delve into. I don't have a definitive answer to you based on my clinical experience because I do circulate in acute care and chronic care hospitals. I don't think there's a difference in terms of the number of individuals who develop pressure injuries. In fact, long-term care may have slightly lower pressure injury problem these days because they're under the microscope, and so there's a lot of attention paid to the care being provided to the residents. I think there's a increase in the ICU setting because, especially with COVID-19, individuals suffering from respiratory problems, and they may be in a position that to facilitate breathing in a high Fowler with the head of bed in the 45-90 degree. A lot of individuals, because of the systemic inflammatory response, low blood pressure, low oxygen level, we know those are risk factors for pressure injury development in the critical care population. And I think in the general population within hospitals, we also see increase in numbers because during the height of the pandemic, individuals are able to get out of the room, so they end up staying in bed most of the time. A lot of people have adopted the habit of watching Netflix and TV on their laptops, and they place the laptops on the lap. They sit on put on the tray table in front of them. So again, they will be sitting in the bed. They will be sliding in the bed most of the time during the day, and that's why we see a high number and high incidence of pressure injuries during the pandemic situation. But I think hopefully we'll be able to come back with a more definitive answer to look at the prevalence and incidence rates of pressure injuries during this time.
Okay, thank you. That's well put. Another question that has come up is, the question is curious about different foams. There is a lot of choice. Any comments you'd like to make?
Yeah, so I think as hopefully I answer some of the components of the question. So you're right, there are many different types of foams and different material out there, and they're different in terms of the composition, thickness, the porosity. So yes, I think based on the evidence available to us, we know that multi-layer foam dressing, they outperform single layer or less layer foam dressing material for pressure injury prevention prophylactically. We also know that the importance of the foam material able to absorb and handle wound fluid. So yeah, so I think and moving forward now, hopefully you can appreciate when you're evaluating, when you're asking your sales rep the different types of foam material, something along the line, asking more intelligent question about the conformability, about the fluid handling capacity, about the layers of material they use. And I think definitely we have to wait for more evidence to see, to compare and evaluate other types of foam material.
Thank you. I think we've got time for one more quick question or comment here. It came across as, are there studies to support prophylactic use of foam dressings in long-term care? I'm not sure there are. I know that, well, I'll let you answer that.
Well, Marika, I think you know the answer way better than I do. Yes, there is one randomized controlled design study published by Professor Santa Maria from Australia. So they did look at the use of foam dressing or the Mepilex material for the care of individuals in long-term care, and there's a significant reduction in pressure injuries in the treatment group in long-term care environment. Yes.
Yes, and thank you. Yes, that was going to be my answer, and you know it quite well. We do have a lot of studies and RCTs that have been done mostly in acute care, but that is definitely one that was done in long-term care. I think we're pretty much running out of time. I'm getting signals. So I would like to say thank you very much, Dr. Wu, for your engaging presentation. You have presented us with some very compelling evidence on rethinking wound care with Mepilex border flex technology. And also to thank all the attendees for attending this session on a Saturday afternoon. We know that your presentations, Kevin, are very engaging, and you certainly do have a big following wherever you go and present. So thank you for presenting on Mölnlycke's behalf. I think right now we'd just like to say to the attendees to please complete the session evaluation, and also to not to forget to go to our exhibit area, the Mölnlycke booth. We have had some technical questions on products. I think it would be more fair for our representatives at the booth to answer those. And also thank you for your attendance, and enjoy the rest of your weekend. Well done. Thank you very much. Bye
Thank you
now.
so much. Thank you.